Okay, everybody, I just got a notification from Luis that we can get started. I'm going to be sharing my screen, so hopefully you guys can see that. A couple things. This is a platform that we, or at least I had not used much before. So if you would look up on the bubble here at the top, and please turn off your audio. I'm hearing a bunch of people in the background at the moment. So if you guys could turn that off, that'd be great. And if you want to chime in, just turn it back on to ask a question. You can take the bubble here on the side and click on that and change your name if you're interested. And then finally, you can turn off your video if you don't want me to see what you're doing at the moment. Okay. Luis, if you are on this and hearing me and texting, just make sure that everything's going smoothly here. And just give me a text because I don't have any input other than just talking at the moment. So anyway, I was asked to give this webinar on some cardiovascular diseases with diving. I am Douglas Ebersole. I'm an interventional cardiologist at the Watson Clinic in Lakeland, Florida. And I'm also the director of the structural heart program at Lakeland Regional Health here in Lakeland, Florida. My background, as mentioned, I'm an interventional cardiologist. That's what pays for my scuba diving. I've been certified since 1974, and I'm a very active recreational, technical, and cave diver, as well as being an IANTD CCR trimix instructor. That combination of being a cardiologist and with an extensive interest in diving led me to be one of the cardiology consultants to the Divers Alert Network. And that led to this presentation, which is the 5 most common emails that I receive regarding diving medicine as my role as a consultant for Dan. Those 5 things are patent perimeter valley, diving with coronary artery disease, atrial fibrillation, which is irregular heart rhythms, diving with blood thinners, quote unquote, and then diving with various devices, specifically diving with pacemakers and diving with defibrillators. We'll start with PFO. That's one of the most common things I get. This is a very, very popular issue in the literature and in diving at the moment. This is an autopsy slide here on the left of someone who obviously didn't do well with their PFO. Actually, this was just a routine finding, was not a cause of death. From a cartoon standpoint, what happens here, if you look at the bottom right of the page, the 2 top chambers, the right atrium and the left atrium, do not have a complete wall between them. What happens is as the wall grows up from the bottom and the wall grows down from the top when we're a fetus, they don't actually meet but overlap and leave a little flap. The reason for this is so that as a fetus, when we're not using our lungs and oxygenated blood is coming from the placenta, that the placenta blood flow, which dumps into the right atrium, can bypass the right side of the heart, go directly into the left atrium, and then be pumped to the brain and other vital organs. When we are born and our lungs open up, there's a lot of decrease in resistance and decrease in pressure on the right side of the heart, and this little flap slams shut and should stay closed. So again, as a fetus, the oxygenated blood comes from the placenta. As the lungs are collapsed, the right heart pressure exceeds the left heart pressure, and the PFO is pushed open, whereas at birth, all these things reverse. This wall will usually kind of seal itself shut within the first 2 years of life, but this fusion is incomplete in about 25% of people, so there's still a little bit of a flap, and that is what is called a patent foramen ovale, or a PFO. It's important to realize that this is just a normal variant and not a disease. When talking to people about this, I bring up the fact that I have blue eyes and I'm left-handed. Both of those things occur in fewer than 10% of the population. I would like to think that's not a disease, but just a normal variant. And the same should be thought of having a PFO. If you put 4 of us in a room, one of the 4 of us is going to have a PFO. That's just a normal expectation. The vast majority of people have no problems from it, however, but occasionally you can get us into trouble. The problem was, prior to the advent of cardiac ultrasound or echocardiography, there was no good way to make this diagnosis. There's no historical findings. There's nothing on physical exam. There's nothing on X-ray. There's nothing on EKG. With ultrasound, you can look either at transthoracic echo, transesophageal echo, or what's called transcranial Doppler to try and make this diagnosis. And we'll talk a little bit about history and kind of what those tests should be as we get farther along here. The first time this came into play was there was an arterial gas embolism through an atrial septal defect, which is an actual hole where the flap didn't even fully form. This was first reported in the British Medical Journal in 1986 and was interesting. This led to a couple of follow-up studies using transthoracic echo, where they found that a significant number of people had PFO who had these unexplained decompression sickness. And while you would expect a PFO in about 25% of people, it was closer to 50% of people that had PFO in these unexplained DCS, kind of providing some information that this may be part of the problem. So we've tried to look and see, okay, exactly how much of a problem is this for divers? There's been a couple of studies, one done from the Annals of Internal Medicine back in 2001, looking at divers and found that people with a patent foramen ovale had about a 4.5-fold increased risk of decompression sickness compared to those without PFO. A second study in the European Heart Journal in 2004, again, found the incidence to be about 5 times higher. So that's concerning when you look at the at first glance, but what you have to look at is the actual incidence. So while the relative increase is 5-fold, the average incidence of decompression sickness with recreational diving is on the order of 2 episodes per 10,000 dives. So if you increase someone's risk 5-fold as a result of having a PFO, that risk goes from 2 per 10,000 dives to 10 per 10,000 dives, or basically 1 in 1,000. So the absolute risk is still very, very small, which is why we do not recommend testing all divers prior to getting certified to look for patent foramen ovale. So there's a very small incidence of decompression sickness with a very large prevalence of PFO, so we do not recommend people routinely get tested. However, there are certain forms of decompression sickness that are associated with patent foramen ovale, and those are the ones that we should actually think about. The 4 types of decompression sickness that are felt to be associated with PFO are the following: cerebral symptoms, so stroke-like symptoms; spinal cord, which is paralysis or urinary retention; cutaneous or skin bends, and skin bends is a classic kind of marbled rash; and inner ear bends, which is manifested by profound vertigo. So if someone were to have one of these forms of decompression sickness, and not your typical type 1 hit with a joint pain, they should be considered at least for being evaluated for patent foramen ovale. So what if we do find that? What if you find you've got a diver and they've got a patent foramen ovale? What do you do with those people if they've had recurrent decompression sickness? I tell all the people that show up in my office that there are 3 plans or 3 options. Number 1 is people could stop diving. I also tell them that usually the people who show up in my office are not going to choose that. But if you've got the person who's been bent a couple of times, they only dive, once a year while on vacation, they may decide to play golf instead. So that's clearly an option. If you don't dive, you don't get bent. The second approach would be to dive more conservatively. The problem here is the bubble load, is the inert gas load. The problem is not necessarily the PFO. So anything you can do to decrease your inert gas load will decrease decompression sickness regardless of whether or not you have a PFO. This has been studied, and the way it was studied was with recreational diving. So the way to, quote, dive conservatively recreationally would be diving well inside the no decompression limits, only doing 1 dive per day, diving nitrox, but have your computer set to air, and then intentional lengthening of safety stops and avoidance of exercise or heavy lifting for several hours after diving. From a technical standpoint, we could do some of the same sorts of things, which would be a matter of setting very conservative gradient factors, padding shallow stop decompression stops, staying in the water a little bit longer even after you've cleared all decompression, limiting the number of dives per day, and avoiding exercise or heavy lifting. So that's the second plan. So if you opt not to discontinue diving altogether, one plans to dive as conservatively as possible for what it is you need to do. I've seen lots of people who are technical diving professionals, and this type of diving conservatively is not manageable because of their job. So if your job requires you to be doing decompression diving, then you do it as safely as possible. And if you still have a problem, then at that point, the other option is PFO closure. This is what the classic PFO device looks like. There's multiple ones available. This is the one that's most popular here in the United States, which is the AMPLATZER device. It's two discs, which are positioned on either side of the atrial septum and kind of clamshell enclosed. Okay, so the way this works, because people are concerned how this is surgery. In my mind, this is just an actual fairly straightforward procedure. This is not surgery. Here's the cartoon representation on the right-hand side. That upper right bubble shows the device being positioned across the PFO with the disc deployed in the left atrium. This is then pulled back, and then the right atrial disc deployed, which is on the bottom right bubble. Once everything's in position, we unscrew the cable that you see there on the top right and leave everything behind. This is all done by a needle stick in the groin. It's not surgery. It does not require any surgery. It's done under conscious sedation, similar to someone having a colonoscopy or an endoscopy. The procedure time takes less than an hour. I send people home the same day. I send people home on aspirin and Plavix or clopidogrel for 3 months. Some physicians have chosen 6 months, so that's up in the eye of the beholder. That's not a hard science. And then normally we get a follow-up echo with bubble study in about 3 months to make sure things are completely closed. And at that point, people can return to diving with no restrictions. So I'll walk you through a classic case here of a patient of mine. This is a 35-year-old technical diver that had multiple type 1 bends, skin bends, and joint pains, but then had 2 episodes of type 2 neurologic bends manifested by transient paralysis, which resolved with recompression therapy. The second episode occurred while diving in truck a long ways from civilization. This got him very concerned because he had an upcoming trip the following year to Bikini Atoll. Yeah. This is our imaging during the procedure. So we image this both with X-ray and with intracardiac ultrasound. On the left side panel, you see the one disc that's now been deployed in the left atrium. The vertical catheter with the little short, dense vertical black line is actually intracardiac ultrasound, which is the image you see on the right side. Again, I think you can imagine the cable coming from about 11 o'clock down to 4 o'clock across the septum, and then you've got that wide disc in the left atrial appendage, or left atrium at this point. We then pull back and deploy the second disc, which you see on the left screen. This is what the image looks like in intracardiac imaging on the right side. Then after it's released, you see again by X-ray imaging on the left and by ultrasound imaging on the right, the 2 discs, and that's pretty much it. People are watched for a matter of a few hours to make sure no bleeding problems and then discharged home. So a lot of this came up because as a cardiologist, I was getting lots and lots of questions. There was not a lot of data out there. So with the assistance of Petar de Noble at DAN, we organized a patent frame ovale study several years ago. This was designed as a prospective study with follow-up for 5 years, looking at divers who chose to have their PFO closed versus those who did not. We logged all their dives, looked at previous exposure histories and so forth, and then followed them up for recurrent decompression episodes as well as for events related to closure of the device. Now, ideally, we would have a perfect study design for this. And in cardiology, what we try to have are what are called randomized double-blind placebo-controlled trials, which means that neither the physician nor the patient know what procedure they had. It's randomized, and then there's follow-up. So the problem with that is that that's a very expensive thing to perform and is not practical. You want that because it eliminates bias. But unfortunately, that wasn't an option here. I mean, we'd like to have this randomized trial, have several hundred divers from around the world randomizing to a PFO closure versus a sham procedure, following up with physicians who were blinded to what happened, and then using endpoints and long-term follow-up. That just simply wasn't practical. So what we had to do was perform an observational study where the patients decided on which therapy they wanted. This obviously puts a lot of bias into the study and is a very significant limitation. because there may be problems with reporting of procedural complications. There may be a problem with recruitment. There may be a therapeutic choice bias, and the willingness to report symptoms may be different in the two different groups. So we did the best we could. We actually did a study with 77 patients enrolled. We had 15 excluded for a variety of reasons and had a follow-up of about 5 to 6 years. This was just published last year in Diving and Hyperbaric Medicine. George Anderson as the first author. Derek Covington and Petar DeNoble on that paper with me as well. Basically, what we found was by baseline demographics, while we did not randomize these people, thankfully there were very similar ages, very similar years of diving, total number of dives and dives per year. The number who stopped diving or dove less was similar in the two groups. The number who dove more trended higher in the closure group, I guess, because of a feeling of confidence they weren't going to have a problem, but was not statistically different. And I won't go into this thing here. This is a chart just to kind of show you that the patients were not a whole lot different. So even though we did not randomize them, they ended up being fairly close to a true randomization. Of note, while I told you that the incidence of decompression sickness for recreational diving should be around 2 episodes per 10,000 dives, in this group we had a very high-risk group because of recurrent problems and because of a lot of technical divers. So the pre-enrollment episodes of decompression sickness were approximately 13 episodes per 10,000 dives in these two various groups, which was not significant between the two groups. So what did we find? What we found was in the closure group with 6 years of follow-up that the incidence decreased from 12.9 episodes per 10,000 dives down to 2.7 per 10,000 dives, which is a statistical five-fold significant reduction, and gets people down to about what you'd expect for a normal incidence of decompression sickness for people without PFOs, which is what you would expect if you actually corrected the problem. The conservative group, which had a follow-up of about 5.5 years, had a fall, which was not statistically significant, but did show a fall from 13.4 to 3.4, which in my mind suggests that diving conservatively is helpful, though not quite as helpful as having the PFO closed. Weaknesses of this is a small sample size, lack of reliable exposure measurements. We didn't have dive computer available on everybody, and it was self-reported incomes. So what should our approach be? The approach for divers with patent frame of VITAE is first to realize that the primary cause is the inert gas bubble, not the PFO. So all these divers should be informed they have an increased risk of decompression sickness, which is probably about 5 times the general diving population. And we should advise divers who have a known PFO to adopt more conservative dive profiles because of this increased risk. And then transcatheter closure could be used in very selected individuals. Usually this is people who have already been diving conservatively, and despite diving as conservatively as they possibly can, they have continued to have recurrent episodes of decompression sickness of the 4 types we talked about, which are cerebral, spinal, skin bends, or inner ear bends. And this is basically, there's a working paper here. This is from the SPUMS, South Pacific Underwater Medical Society. There's also the exact same document from the Undersea Hyperbaric Medical Society here in North America, and these are their recommendations. There is no recommendation to routinely screen for PFO at the time of dive medical fitness. You should consider investigating for PFO if you have people with those 4 types of decompression sickness we talked about: cerebral, spinal, cutaneous, or inner ear. There is some correlation between migraine headaches with aura and PFO. We could talk about that if people have questions. If people have a history of cryptogenic stroke, they should be considered for evaluation, because that's the main reason we actually close PFOs in cardiology, is for young people with what we call cryptogenic stroke, which means a stroke with no other source other than having found a PFO. And there is some familial representation to this. If screening is performed, it needs to be done with a bubble study. The recommendation is transthoracic echo, not transesophageal echo with a first test. With the agitated setting, that's a bubble study, and the bubble study should also have provocative maneuvers such as Valsalva or a sniff test. The reason I bring this up is That is not a routine procedure performed with regular echoes. If you just get a regular echo for some other reason, it's not going to involve a bubble study, and it's not going to involve provocative maneuvers. So the echocardiographer, the technician, and the doctor both need to know what it is we're looking for to make sure you get the best test. If you have a positive test, realize that these can be judged by size, by how much of a gap there is in the flap, and also by how many bubbles are crossing over the septum. Small shunts are associated with increased risk, but not as much as large shunts. And unfortunately, it's not a dichotomy. It's more of a general idea of how big or how small this is, but that's something just to kind of be aware of. Again, like I mentioned, if you do have a PFO, you can either stop diving, dive conservatively, or close the PFO, and you should not return to diving until closure's been confirmed, which is usually on a 3-month post-procedure echo. So that's kind of the take-home message on email number 1 I get, which is patent frame ovale. These next ones will be much faster. Number 2 is diving with coronary artery disease. And we think of coronary artery disease as something that happens to our parents or our grandparents, but that's not always the case. We also think it's something that's going to happen to people with certain other underlying medical conditions, which also is not necessarily the case. This is an actual case that happened to me approximately 10 years ago or so. I was at home when I got a phone call. There was sudden death for this patient at a gas station at approximately 3 a.m. while he was pumping gas. Bystander CPR was initiated. The emergency medical services were activated and brought the patient to our emergency department, where he was found to be having an acute anterior wall heart attack. And our STEMI call, our acute MI team, was called, and we all scrambled in from home. Of note, this patient had no history of smoking. They had no history of diabetes. They had no history of hypertension. They had no history of hypercholesterolemia, and they had no family history of coronary artery disease. This is what their EKG looked like on presentation. I know a lot of you probably don't spend a lot of time looking at EKGs, but trust me, you don't want your EKG to look like it.
Yeah, didn't recognize.
Yeah. Okay. By the way, I can hear people in the background. If you happen to look at the bubble and could mute your microphone, that would be great. Thank you. Okay, anyway, so this is what their EKG looked like on presentation. Those big, tall, peaking waves in the ones labeled V1, V2, V3 are indicative of a heart attack involving the very front wall of the heart at the very proximal area of what's called the left anterior descending. We call this the, quote, widowmaker, unquote. And as you can imagine, there's no real good reason we would call it that. These cath films don't project very well, but this is the blockage he had in his proximal LAD right as it came off the left main coronary. This is the CIRCUMFLEX, which also had an area of approximately 60 or 70% narrowing, and his right coronary artery, the third of your heart's 3 vessels, also had an area of approximately 40 or 50% narrowing. We placed a 3.5 millimeter stent. The patient did quite well. So what's the most interesting part of this case? Well, the most interesting part of this case to me was the following. This patient was 32 years old. So this was a 32-year-old man with no history of any traditional cardiac risk factors, yet despite that had a life-threatening event at age 32. So just realize that this is not necessarily a disease of our parents and our grandparents, but this happens to young people as well. Okay, with diving, there are about 100 fatalities per year scuba diving. How does this correlate to other things? Well, it's on this average of the same number of people who die from swallowing ballpoint pens and die from falling coconuts, and markedly lower than those electrocuted by toasters or accidental gunfire. So it's a relatively small number of people who die doing our report each year, but if there's something we can do to lower those numbers, obviously we clearly should. The reason I bring those numbers up is it's felt that ischemic heart disease, coronary artery disease, is involved in over 25% of scuba fatalities and those over the age of 35. Now, I'm not talking about age over 65, is there age over 35. Again, if people can mute their microphones by looking at the bubble on the screen, that'd be very helpful so we don't overhear your conversation. Thank you very much. So, the issue with coronary disease and diving is that there's now a large group of people over the age of 45 that scuba dive for 2 reasons. There's those people who began diving very, very young, like myself, and are now much older. And also, as we have made scuba diving safer from better training and better equipment, more people over the age of 45 are actually taking up scuba diving as a first-time activity. The problem is we're all getting older. This is Arnold Schwarzenegger back in his heyday, followed by Arnold Schwarzenegger in today's world. I'm sure Arnold sees himself more as the picture on the left and less as picture on the right, and not just being mean to Arnold. This happens to all of us. This is me scuba diving in 1978 versus scuba diving now. I'm sure in my mind I still think I'm that guy on the left, but my physiology and so forth is not. And I need to be aware of that. So we all have to be aware as we get older, our risks are going to increase. Of course, there are the exceptions that prove the rule. This is Ron and Valerie Taylor of Blue Water White Death fame and Stan Waterman in their 80s, all going shark diving at Tiger Beach with my buddy Jim Abernathy. We all want to be these people. So how do we do that? The way to do this is to try to decrease our likelihood of developing these serious diseases. The problem with coronary disease is that despite the Surgeon General's warning in 1968 about cigarette smoking, there's still about 650,000 Americans who die from coronary disease every year. And unfortunately, like that 32-year-old I showed you, having a heart attack is the most common presentation. And unfortunately, another group, about 15 to 20% of people just present with sudden death, and we're unable to help those people. You know, hopefully, if people were to present with chest pain all the time, that would be quite easy because we could just perform treadmill testing and catch these people. Unfortunately, for a large proportion of the population, their first ever symptom is either sudden death or a heart attack. And those people we have a problem with. Okay. And of course, it's also important to realize that coronary disease is the most common cause of sudden cardiac death that occurs while scuba diving. Traditional risk factors: age, smoking, cholesterol, diabetes, hypertension, and family history. Some of these we can control, other ones we cannot. Obviously, we cannot change the fact that we're getting older. We cannot change our family history because none of us pick our parents. However, if people smoke, they can stop. If they have high cholesterol, diabetes, or high blood pressure, those can be treated. And that's the best way to help these people. Okay, so who should be screened for this? Well, the screening for coronary disease in diving is similar to any kind of activity. So that if anybody was going to take up exercising in middle age or later for the first time, and so they want to all of a sudden start jogging or start biking or something, if they're over the age of 40, it's never a bad idea if they've not exercised before to do a treadmill test. This can also be applied to people under the age of 40 if they're very poorly conditioned. It used to be recommended that people be able to achieve what's called 13 METs on a treadmill test. That is a lot of exercise, and a lot of people, even a lot of people listening to this right now, could not probably hit that number. That's based on some exercise physiology numbers. But that recently has been lowered, and it's currently felt that if you can sustain walking at a pace of about 2 miles in 24 minutes, that's adequate exercise for recreational diving. So if you have a student or a friend or a family member or yourself, and you're concerned of how physically fit you need to participate in recreational diving, that's a good benchmark. So walking 2 miles in under 25 minutes would be ideal. So what if someone actually has coronary disease? Who cannot dive? The vast majority of people with coronary artery disease can still dive unless they have active angina, despite medication and revascularization, or they've had a history of a heart attack that left them with a poor heart muscle function. And the reason for that is because with immersion underwater, you get a shift of about 700 cc's of fluid into your central circulation, and with weakened heart muscles, this can put people into heart failure. And if people have ischemia, meaning blood flow limitation problems that result in dangerous heart rhythms, clearly those people should not dive. But otherwise, people should be able to return to diving even if they've developed coronary disease. So the majority of the questions I get along this line in terms of emails are somebody calls me and says they've had a heart attack, they had chest pain leading to either bypass surgery or stenting, and they want to know, can they return to diving? And the recommendations are the following. If somebody has had revascularization with stents or with bypass surgery, and they have a normal treadmill, and they have normal heart muscle function, they have no drugs that inhibit their exercise tolerance, and they can have annual treadmill testing that remains normal, those people can continue diving without limitation. We do have to counsel them to the increased risk because they do have higher risk than people without coronary disease, but it's not felt to be high enough to tell them they cannot dive. Now, obviously, this does not apply to dive professionals or with technical diving, and that has to be taken on a case-by-case basis. All right. The next few will go quite quickly here. Atrial fibrillation. This is an irregular heart rhythm that's very, very common as we get older in life. It happens very uncommonly in people under the age of 40 or so, but once we get into our 60s, it's fairly common and becomes almost ubiquitous into the 90s, 80s, and 90s. The problem with this is it increases people's stroke risk by 5-fold, and accounts for about 15 to 20% of all strokes. And unfortunately, the strokes associated with atrial fibrillation are quite bad, with a 50% chance. Greater chance of disability or death compared to routine strokes. This comes in from a diving standpoint. By the way, once again, if people could please look at their microphone on their bubble and turn that off and use their microphone, that would be very, very helpful.
Shut down. Oh yeah, everybody's close.
I don't know if you're hearing me or not. Anyway, I'm sorry if this is annoying to people.
Yes.
The issue with atrial fibrillation,
Emerald Island, Beach, and people are pressuring Roy Cooper to.
I hope someone can hear me right now. Please turn off your microphone. Please mute your microphone.
There's now Hey, Doug, it's Luis. Hold on.
Yeah.
Let me just mute everybody and then only you.
Okay, thank you. Okay. Anyway, the concern with atrial fibrillation and diving is twofold. One is that some people have very poor control of the rate of this. It tends to want to be a very fast rhythm and can be very, very uncomfortable for people underwater, so that they are incapacitated by these rapid heart rates underwater. That can also be quite dangerous. That's not real common, and most people, when they go into this, are not incapacitated from it, so that's not a real major concern with diving. The other issue is because of the stroke risk, the mainstay of therapy is blood thinners or anticoagulation, which markedly decreases stroke but does increase bleeding risks, so that people need to be aware of that. This is kind of how we judge the risks of people for having a stroke with atrial fibrillation. It's a variety of risk factors. But the point I would put in here is the bleeding risks. In general, the major bleeding risk being on blood thinners like Coumadin or what they call the NOACs, the newer agents, dabigatran, rivaroxaban, or apixaban, is around 2 to 3% per year, major or serious bleeds, but much lower than their risk of stroke would be if they were not on blood thinners. So that's kind of why we recommend these. As far as diving goes, oral anticoagulation is not an absolute contraindication in diving, and divers have to individually weigh the risks and benefits. So I talk with each of them about their desire to dive and their risks of bleeding. There is an increased risk of minor bleeding with trauma, such as cuts or bites or scrapes, or with barotrauma. So that if you were to have a sinus squeeze or an ear squeeze, it'd be more likely to have bleeding from that. That's not usually a life-threatening problem, but it is annoying and needs to be aware of. Additionally, there is a theoretical risk. There's not a lot of data on this, but something people need to at least be aware of, that God forbid you were to have a decompression event and need recompression therapy. If this was a neurologic event in the spinal cord or the brain, you could imagine that injury could be more likely to have bleeding into the injury if people were on blood thinners than not on blood thinners, and that could make the deficit worse and the outcome worse, period. Again, that's a theoretical concern and has not been proven, but at least needs to be in everyone's mind when we discuss diving on blood thinners with our patients. Okay, what about pacemakers? I get this as well. So somebody will say, hey, I had a pacemaker placed and I want to return to diving. What do I do? I will tell you that there's absolutely no dive medicine training in routine medical schools, and we're all trained to say, above all, do no harm. So a lot of physicians will tell you, oh, you have a pacemaker, well, then you should never dive. And that's not unreasonable, but I don't think needs to be quite that conservative. The alternative approach would be to say, first off, why do you have a pacemaker? Because pacemakers are put in for a variety of different reasons. Second question would be, is the individual we're talking about pacemaker dependent? Meaning, was it put in as kind of a backup and they have their own heart rhythm and this is just there in case they get into trouble? Or do they have no underlying heart rhythm whatsoever, so they are 100% dependent on that pacemaker, and any malfunction of that pacemaker would put them in a life-threatening situation? And then the most important question is, what is the pacemaker rated to in terms of depth rating? Diver candidates with pacemakers are not allowed in commercial, military, or scientific diving, but that's not really what we're talking about here. From sport divers, it must be individualized, like I mentioned, whether or not they are pacemaker dependent. Is their exercise tolerance limited? Because some pacemakers are not rate dependent, are not rate responsive, so that as you exercise, they may not increase the rate. So people try to exercise with no increase in heart rate and fatigue sooner. And then the other thing is looking at the depth rating of the pacemaker. These are metallic boxes which do have air spaces inside, so they can get compressed and can malfunction if taken to too deep of a rating. This is just one study that looked at MEDTRONIC. I'm not bashing or promoting MEDTRONIC as a company. This is just the one information we had. This just showed that the rate responsiveness began to diminish once you got deeper than 66 feet. The devices began to just pace at the lower rate and would no longer be rate responsive despite increase in activity. And then once you got the equivalent of about 132 feet or 40 meters, the actual titanium can began to compress and actually deform. As a result, most of our MEDTRONIC devices are rated to about 100 feet of salt water. Some of the other devices are rated deeper, so that if, God forbid, you were to need a pacemaker, you may want your cardiologist to look and see what the depth rating is of a particular device. That may allow you to dive deeper, depending on a variety of other situations. Okay, well, defibrillators. Defibrillators are the shock boxes for people who have dangerous heart rhythms, so I get those calls initially, or fairly frequently as well. The problem here is that the vast majority of people who have defibrillators, true shock boxes, have enough underlying heart disease on their own that disqualifies them from diving. So it's not usually the fact that they have a defibrillator, it's why they have a defibrillator that's the problem. The majority of these people have very severe heart muscle function, which we talked about before as being a problem. They have very severe coronary artery disease, they have very poor exercise tolerance, and they have very dangerous heart rhythms that, if occurring underwater, would cause loss of consciousness and drowning. So the vast majority of people with these particular devices are not able to dive. Okay, in conclusion, the 5 emails that I get most commonly regarding cardiac issues because of my relationship with Dan are for PFO, coronary artery disease, atrial fibrillation, blood thinners, and devices. For PFOs, just realize that the 4 types of decompression sickness associated with PFO are cerebral, that's stroke-like symptoms, spinal, which is paralysis or urinary retention, cutaneous, which is skin bends, and inner ear, which is vertigo. Those are the ones most commonly associated with PFO and should prompt the consideration of investigation. If people have recurrent decompression sickness of those types, your options are either stopping diving, diving conservatively as possible, or considering PFO closure after appropriate discussions with your cardiologist. For people with coronary artery disease, the key before returning to diving is to assess them for ischemia with treadmill testing. Look at their LV function, heart muscle function with an echo, and treadmill testing, look for their functional capacity. For patients with atrial fibrillation, the key is rate and symptom control. If the rate can be well controlled, there's no reason from that standpoint that they should not be able to dive. We put the appropriate patients on oral anticoagulation based on their stroke risk, realizing that oral anticoagulation is not an absolute contraindication of diving, but does have an increased risk of more minor bleeding that divers need to be aware of. And finally, for the implantable devices, pacemakers are not an absolute contraindication diving as long as you look at what the indication for the pacemaker is, whether or not they are 100% pacemaker dependent, and then what the depth rating of the device is. And for defibrillators, again, like I mentioned, almost always this is a contraindication diving based on the indication for the device, not the device itself. And I think that's it. So I'm going to come off my screen here. We can go to the chat feature as well. And people can either type in comments or we can turn people's microphones off mute now and people can ask questions. So thank you. Okay, I see something that just says about lung shunts. I don't know what the question of that is unless one of the issues is there are right to left shunting we're talking about, which is the patent frame of valet from that little flap. There are also right to left shunts from intrapulmonary shunts. So you could have, you could bypass the filtering effect of the lungs from bubbles from decompression stress because of a PFO, but some people also have an intact atrial septum, so that's not where it's occurring, but they still get shunting. And what happens there is the pulmonary artery can have what's called an arteriovenous malformation, and the bubbles can go from the pulmonary artery into the pulmonary veins and get back to the right heart and cause air gas embolism effects similar to a PFO. That's a little bit more difficult test to, or a little bit more difficult condition to diagnose and a little bit more difficult to treat. The way we look for that is we inject bubbles with a transesophageal echo. If you have a PFO, you'll see the bubbles go directly into the left atrium from the right atrium instantly. However, sometimes if it takes several heartbeats and then all of a sudden they show up, that can be indicative of an intrapulmonary shunt, which can then be, the diagnosis can then be made with a CTA, CT angiogram of the chest, and interventional radiologists can potentially coil that AVM off if need be. So that's how that would go into play. I hope that answers your question. You're very welcome. And the next question is, what if you have an irregular heartbeat in the past but is now normal? Again, there's a whole variety of what's called irregular heartbeats. So the first question would be what the rhythm you actually had was. A lot of people have little skip beats, either what we call premature atrial contractions or premature ventricular contractions, which are completely benign and are no contraindication diving whatsoever. There are other fast heart rhythms which are not atrial fibrillation, most of which are completely benign. And as long as people are not having symptoms from that, people can dive with those as well. There are some rapid heartbeats called ventricular tachycardia, which would be very dangerous to dive with. So the main thing is if you have irregular heartbeats or you've had a history of an irregular heart rhythm, to find out from your physician truly what the mechanism of that irregular rhythm was, the vast majority of which are not a problem with diving whatsoever. I see Mark says it was atrial fibrillation. If you've had atrial fibrillation in the past, it's well controlled now, or you're having it no more, I would see no problem with diving whatsoever, as long as it's well controlled. The question simply comes up about blood thinners. If you're not on blood thinners, it sounds like you had it for 2 weeks and it went away. That may have been related to something else. Sometimes people will have a predilection towards atrial fibrillation around the setting of an illness or stress or heart surgery or some other event. Will go into atrial fibrillation and then it never recurs. So that should not be a real problem for you whatsoever. If it was only for 2 weeks and went away, you probably never placed on anticoagulation. So that's probably not an issue either. Again, if for some reason someone is on long-term anticoagulation, like I mentioned, that's not a contraindication, but just something to be aware of from the bleeding. Again, then the next one is, was there any record of overall body mass index or body fat percentage as a contributing factor in the study? I'm not sure which study you're talking about. If you're talking about our study or you're talking about just the incidence of with regards to, I'm sorry, bouncing around here. With regards to PFO, does the stroke-like syndrome come from embolic like TA? If so, does the age responding? With regards to PFO, does the stroke-like syndrome come from emboli like TAA? Yes, that's the feeling. This acts like an air gas embolism, which in that case went to the brain as opposed to some other organ. So yes, that's what the feeling is. Aortic stenosis is a separate problem, but that also obviously can cause the calcification on the aortic valve, could break loose and cause TIA as well. Pulmonary embolism is blood clot going to the lungs. So that would be more of a problem of blood clots in the legs that went to the lungs and caused pulmonary emboli. The problem with the blood clots, if you have a PFO, is they could cross over the PFO, and a as opposed to causing a pulmonary emboli, could cause a stroke. That's that cryptogenic stroke I was talking about in young people, and is the main reason we actually closed PFOs to the general population, not divers per se. And again, I'm getting kind of confused with, for our study, we do not have, there was no incidence of any difference between the two groups in terms of body mass index, but we weren't really looking at that. You would suspect that obese people would have a higher incidence of decompression sickness because fat tissue does not on-gas or off-gas as efficiently as lean muscle tissue. Okay, what if someone has no cholesterol, diabetes, but sudden stress in life and his blood pressure higher than normal, not to respect only healthy lifestyle? Again, risk factor-wise, the key is just to be as healthy as you can. So sudden stress, anything we do to decrease stress obviously is helpful. If cholesterol is normal, diabetes is not present, and blood pressure can be controlled with medications or lifestyle changes, then I think nothing further needs to be done. The vast majority of people with all these things can dive safely. And the way to think of these risk factors we were talking about is simply risk factors for heart problems. In and of themselves are not necessarily a problem other than diabetes, which is a whole separate talk. Oh, they lost my audio again? Sorry. Hopefully you guys can hear me. Let me know if you cannot, or I guess if you can, someone type in that you can hear me now. If a diver experiences mild skin bends, okay, I can hear you. Okay, good, thanks. If a diver experiences mild skin bends without clear reason, it's true that hyperexia here who get tested. That's debatable, and I think that's somewhat in the eye of the beholder. For an unexplained episode of skin bends, I think it's very reasonable to get tested with a transthoracic echo. I don't think it's required by any stretch of imagination. If somebody were having multiple episodes, I would recommend that because you may be getting skin bends now, but the next one may be a severe neurologic hit. But a single episode of skin bends, depending on the dive profile and depending on the diver and what their need for diving from a professional standpoint and so forth is, you may or may not want to get tested with a single episode of skin bends.